Thank you very much, Dr. Archana and the Wipro team for having me here. Like the introduction said, my work is currently deeply in community health to bring the use of digital technology in the service of community health workers. So that's the summary of my work across 3 different projects. And today I'd like to talk to you about what technology can do in each of your organization's charter. Basically give you the big picture overview, which helps you get started. And as you go deeper, you will figure out your own ways to maximize your output using all the tools that are already out there in this space. Right? So it's more an overview session, and do stop and ask me any questions along the way. You need not hold on to it till the end. When I went about looking for, resources on community health, across media articles, presentations of this kind, technical papers, this was the big question: is technology a boon or a bane? And I had, of course, by that time already decided it was a boon, but I said no, if this is the question in the mind of so many people, we should make an earnest effort to explore it. Spend some time on this question, because only if we make our peace with the answer can we then find answers for ourselves. So, in summary, technology, can it give something that advances health outcomes? Or is it something in its own, serving its own purpose, right? Is health just another use case for technology to get ahead in its objectives, is the fundamental question. So let me start with a story. कुछ दिन पहले मैं राजस्थान गई थी, झाडोल जिले में. Okay. झाडोल में इसीलिए गई क्योंकि उसके पहले सप्ताह में मैंने CM डैशबोर्ड देखा. I saw the CM dashboard for how health in the state has progressed. It was a very nice red, amber, green, more green than amber, more amber than red, very little red, compared to, say, a 2017 picture which was all red, little bit amber, very little green. Everything seemed to have improved despite a pandemic in between, the Nirogi Rajasthan digitization scheme, all data from the field, going into the district, going into the state, the plumbing had been done. Asha had moved from using registers to using apps, right? All of this was a very, very nice story. Then I said, let's go see what an Anganwadi in the most red district of the state looks like. So Anganwadi was a 1 room and a kitchen. लेकिन kitchen को kitchen की तरह use नहीं कर रहे थे. It was a storage of kabadi, not even storage of good things, but storage of kabadi. आशा 7 रजिस्टर मेंटेन कर रही थी, और उसमें से उन्होंने कहा 2 तो हमको ऐसे ही भरना पड़ता है, उसको हम किसी चीज़ में यूज़ नहीं करते, उसका कुछ रिपोर्टिंग नहीं होता, लेकिन जब विजिट्स होती हैं, ऑडिट्स होती हैं, तो हमको भरा हुआ दिखाना पड़ता है. उसके ऊपर वो ऐप यूज़ कर रही थी, तो ऐप की वजह से वो रजिस्टर का काम कम नहीं हुआ था. इनफैक्ट 1 रजिस्टर ज़्यादा हुआ था. हर रजिस्टर में बहुत अच्छी डेटा थी, लेकिन जो 10 बच्चे थे उनको खाना नहीं मिल रहा था क्योंकि किचन तो कबाड़ी है. तो हमने पूछा इनके खाने का क्या होता है, किचन चल क्यों नहीं रहा? तो उन्होंने कहा क्योंकि यहाँ का राशन चोरी हो जाता है ना. तो अगर राशन चोरी हो जाता है तो बच्चे क्या खाते हैं? हम घर से कुछ बना के ला के खिलाते हैं. लेकिन दिख रहा था कि ये सिर्फ स्टंटिंग नहीं थी, ये एक्सट्रीम मैल न्यूट्रिशन की केस थी, जहाँ पे 10 बच्चे 7 साल के थे लेकिन 3-4 साल के दिख रहे थे. तो अगर ग्राउंड रियलिटीज़ नहीं बदली हैं तो इतनी अच्छे डैशबोर्ड का क्या फ़ायदा? तो हमने पूछा आपके डेटा में तो सारे ग्रीन दिख रहे हैं, तो आप वेइंग मशीन कहाँ है? मैंने कहा वेइंग मशीन तो बहुत दिनों से काम नहीं कर रहा. तो आपने डेटा कैसे भरा? और वो एक दूसरे की शक्ल देख रहे हैं कि अब क्या जवाब दें. तो फिर उनमें से एक ने कहा जब ANM दीदी आती हैं, जो महीने में 1 बार होता है, क्योंकि ये वो ज़िला है जहाँ डेंसिटी ऑफ पॉपुलेशन इतना कम है कि ANM दीदी महीने में सिर्फ 1 बार आती हैं. और एक बार आने से जो अपनी मशीन में वो मेजर करती हैं वो लिखते हैं, लेकिन डेटा रोज़ का था, कहीं बिटवीन दोज मेजरमेंट्स हम वही मेजर लिख देते हैं, लेकिन और सारे ग्रीन थे. सो एनीवे, पॉइंट ऑफ द स्टोरी, राइट, if all the tech gives you nice dashboards but does not change reality on the ground, then we've gone astray in this pursuit of digitization. It's a case of 100% digital but 0% movement in the realities that the tech was supposed to solve, because the promise was that of transparency, one version of truth that all officials along the way would see. I'll pause here and ask, does the story resonate with you? आपने ऐसा देखा है ना, काफ़ी जगह पे. दूसरी बात ये है कि जब टेक्नोलॉजी वाले आते हैं तो ऐसा रोज़ी पिक्चर दिखाते हैं जैसे उसी से सब कुछ सॉल्व हो जाता है ना, और भूल जाते हैं कि फाइनली देयर इज़ अ वेरी ह्यूज ह्यूमन एलिमेंट इन केयर गिविंग, राइट. तो केयर गिविंग कहाँ से आएगी, उसका जवाब बहुत कम लोगों के पास रहता है. और तीसरा ये कि हमें डीपली इंटरनलाइज करना है कि हमने अपनी ज़िंदगियों में टेक्नोलॉजी को बहुत अच्छी तरह से यूज़ किया है. अब सोचिए आप यहाँ कैसे आए, आपका टिकट कैसे बना, नॉट जस्ट टू कम फ्रॉम say Aurangabad to Hyderabad, but even to go from your home to the airport. आपने रास्ते में क्या खाया, आपने कैसे पेमेंट्स करे, वो हर चीज़ में हमने डिजिटल का इतना अच्छे से इस्तेमाल किया है कि हमारी ज़िंदगियाँ बहुत सुधर गई हैं. But for everyone on the other side of the digital divide, these benefits, thanks to UPI, have started to reach. Even without a smartphone, you can be a recipient of money. But in a lot of use cases, it has not happened. The risk in health is very, very large, right? हम Fitbit पहन के या अपना Apple Watch पहन के अपना ओवर मेजरमेंट करेंगे, राइट. दिन के हर पल हम जानेंगे हमारा हार्ट बीट कैसा है, हमारा ब्लड शुगर कैसा है, राइट. एंड you'll benefit from it because you will have your अर्ली वार्निंग्स, आप हेल्थ सीकिंग ठीक से करेंगे. पर उनका क्या जिनके पास शायद स्मार्टफोन भी नहीं है, लीव अलोन वेरेबल्स एंड अदर फैंसी गैजेट्स. गैंग्रीन हम में से किसी के नेटवर्क में किसी को, आपको पता है किसी को हुआ है, राइट. हमारे पहचान के लोगों के, राइट, लाइक हमारे रिश्तेदारों में या दोस्तों में किसी को गैंग्रीन हुआ है? अच्छा. मगर अगर आप देखें, there are 36% of peripheral neuropathy cases that turn into gangrene. 36 is a very large number. But not even 1% of that belongs to a middle class family and above. ये गरीबों की बीमारी है, क्योंकि ये वो बीमारी है जिसका आप 15 बार टेस्ट करके, 15 प्रीवियस स्टेजेस में आप उसको जांच कर सकते थे, राइट. पर इंसान तब जाके उसका टेस्ट करवाता है और उसको पता चलता है जब उससे सिम्टम्स सही नहीं जाती, राइट. अगर वो पुअर है, राइट. फॉर द पुअर इन द कंट्री, यू ओनली गो एंड गेट टेस्टेड आउट and find something as severe as gangrene, which is life-threatening, when you can no longer bear the symptoms. Till then you say, I will not go to a doctor because it will cost me huge out-of-pocket expenses. Or if I go to public health care, there is a severe apathy that I have to deal with, right? I do not get the personalized attention. Doctor is in a hurry to write paracetamol because I said pain and tell me to make space for the next person in the queue. Now this digital divide is what can only be bridged with technology. So you have to basically deeply internalize that technology, like money, you never ask the question, is money good or bad, right? Money is good if it is in the hands of the right people with the right intent who do the right things with that money. Same money can buy drugs and alcohol, right? But a person with good intent, good ideas, good heart, without money cannot do much. They need money to do the work that results in good in the world. It's the same with technology. right? And technology in the hands of a community health worker who's focusing on everyone that cannot directly access it is a massive value proposition. So I would take a moment to request all community health organizations to see their role as a bridge between people that have needs to the technology that can help solve those needs. Right? So that's the fundamental takeaway from this conversation. The rest of it is how to do this. So why is health different from UPI or any of those other use cases which have seen rapid advancement? It is because it is a complex issue. Right? We're trying to solve for the apathy of public health care on one end, the profit-seeking nature of private healthcare on the other, and below the surface are the problems of information asymmetry. Right? A woman in a low-income community has white discharge. She doesn't know if it is a natural process or is it a symptom of PCOS or something more severe. How do you bridge the information gap? When she goes to a physician and they say, "Aapka hysterectomy karana hai," you don't know, is it really that severe that I have to take such an extreme step? And who do I ask, right? So the ability to say, yes, I'm getting very good, timely advice that can save my life, to saying, hey, this is unnecessary advice, I don't know what to do with it, can only be bridged by access to information given to her by people she trusts, right? And I'm kind of seeing each of you in that role. The second is misaligned interests. Whether it is government or a private practitioner or a lab or a pharmacist, they each have their interest, although they are service-minded. Right? There is a secondary objective of running a viable business, etc., to fulfill. Again, it is the community health worker who can advocate on behalf of the patient. Right? You're almost like a fiduciary for her. And you are the one person going to put her interest at the center and engage with all these providers, right? And make sure that whatever she gets at the end of all these interactions actually helps to improve her health outcomes. Now there's this very interesting advancement in technology that makes this the right time to have this conversation. Like we said, people wait till they can no longer bear symptoms to get tested in a large lab or a hospital. What is happening as we speak is the ability to do what a lab or a hospital does, using devices that fit into the bag of a community health worker. Right. This is largely due to AI, sound processing, image processing, where a community health worker can take simple photographs or audio clips and send it to the lab, or where the processing happens, which is largely digital. It's not even a lab with equipment. And then there are some devices like a mobile EKG, which does what an ECG does, a mobile X-ray or a ultrasound machine, right? Which has made this conversation very, very timely. These innovations that have come in the last 3 years will change the game as far as community health is concerned. So the work needs to happen in two distinct areas, right? The first is technology that strengthens health systems. And then there's technology that serves the patient directly. In the Jhadol story that I told you, the need is for technology to strengthen health systems. But you cannot have the latter without the former. So I also said you have the whole device ecosystem coming up, which takes measurements, etc. A weighing machine or an EKG or a cancer scan, which finally requires data entry, is useless, right? Because it is at the point of human data entry that data fudging happens. So the first biggest opportunity in improving health systems that I'd like to call out is the opportunity to use technology to prevent fudging of digital data. Right? You have today a digital mission, right? The Ayushman Bharat digital mission and an Aabha ID, and the public infrastructure created where each person can have their personal health record on the cloud, like how you and I have our DigiLocker. It's a longitudinal record, whether I go to a lab here or a lab there, whether I go to doctor in PHC or go to private doctor, all my records land up in my personal health record. And when this ecosystem of devices that do tests and measurements kicks in, it happens with the same biometric scan that is used in Aabha. The system recognizes me and puts my test result in my personal health record. No human hands touching the data. Right? Foolproof mechanism to make sure that what shows in the CM dashboard is the reality on the ground. Now, there's so much of personal data that's going to be managed if everyone is going to get tested for NCDs, regular monitoring of various parameters, mental health screening, right? A lot of this is very sensitive. So how do I make sure that my data stays with me and does not get misused? I need a consent layer. Right. It is there in my personal health record. My doctor gets to see it only when I give consent. So it is an OTP-based transactional consent for the use of that conversation. Right? This is therefore a huge mechanism for access, agency, and privacy. Right? It's compliant with all the privacy laws of the country. I also need to know who is the person I need to go to once I detect a negative result, right? So I need a very easy discovery of all practitioners. I should not travel 150 kilometers, spending on bus fare, spending on stay, for potentially a free consultation as far as health is concerned, right? And there might be cheaper options even if I pay a little money to a private practitioner. The choice should be mine as a citizen, right? So the other public health infrastructure is the directory of care providers with the ratings of how has their performance been, right? How has their mix of happy versus unhappy customers been on some, like you have in your food apps, a 5-star rating. And finally, the health system improvement comes from debottling the most scarce resources. A specialist doctor should not spend an hour looking at health history of the patient, right? Asking questions, taking an oral history, which is what happens a lot of times. They are the most scarce resource. Think of a gynecologist in a place like Bahraich, a region where there are no female doctors, leave alone a female gynecologist. Now, the one gynecologist that is there is only able to see a certain small number of patients in a day, because a lot of time goes in taking oral history, doing administrative tasks, right? But if you could make that a resource that is available for very efficient transactions, the history coming out of health records, visualized for them, perhaps even summarized in a 200-word audio bite that they can listen to, right? So much of efficiencies can come through technology. And that is required at every level, because we are still a country that spends less than, just over 1.5% of our GDP on the health budgets, right? We have a doctor-patient ratio which is nowhere near where it needs to be for a population of our complexity. That part of technology to improve health systems is very, very essential. Now coming to the community health side, which is this immense opportunity we have in taking away a big chunk of that curative spending to the preventive space, right? Today, preventive doesn't happen because tests are expensive. How can you do population scale screening? Those of you who have done tuberculosis active case finding will know how expensive it is to do door-to-door sputum sample collections and test every sample. But what if you could use a proxy for the detailed sputum test that tells you who the high risk or most likely candidates are, and only do the detailed, right, the confirmatory test in a lab for them, but 100% of the population gets tested on something as simple as khans ke dikhao, aapka audio file lenge, right? That's the easiest thing. And from the nature of the cough, you can tell, is it TB, is it a common cough, is it COVID-related cough, is it lung cancer, right? That's how much technology has evolved to give you these preliminary screening results. And this can be done at the doorstep. The significance of at the doorstep is that the person taking the test does not need to be a medical expert. They are a community health worker, right? Dr. Pratibha, I'll ask you to make the comment on the retinopathy thing that you had mentioned as an example of someone that is not highly qualified being able to do that, even though to do it by a doctor requires very special skills. अब शेयर कर रही थी तो आप ग्रुप के साथ प्लीज शेयर कीजिए.
One is in community ophthalmology and one is in community ear screening. In community ear screening, we are doing ear screening in our area, and in ophthalmology, we are doing retinopathy. We are using that device to, what do you call, digital, AI-based device of to rule out the retinopathy of prematurity. Yes, this is the simple device we are using in our area, and one is what do you say, digital device in ear screening program. That is the instrument called EntraView, 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 which diagnose that common ear diseases, and other thing is retinopathy of to diagnose retinopathy of prematurity. That instrument called what we call that slip of tongue. yes, I will share sometime when I
Thank you
recall
so
it.
much.
Thank you.
We with AI technology, Swasa is there. Swasa app.
I have your name on the slide. Yes.
Yeah, Swasa. We are using a Swasa app. So with this app, we are able to identify the risk cases, and we are able to link to the DMC so that the treatment is going on well, and more cases are able to reach out to the communities. If a risk person is there having a cough, we'll ask them to wear a mask, and the person who is taking also should take a mask so that it cannot be transmitted. So his cough is being recorded thrice, and before that we will be adding all his symptoms in the digital form so that the risk of lung is clearly mentioned by the end of the report, ma'am. So it's very useful, ma'am. We are able to link around 15 cases. Among them, 7 are on treatment, ma'am. Thank you.
Fluid coming out of my breast nipples. So doctors advised me to go for mammo. to rule out whether it's any lump in the breast. Then they couldn't do it in the mammo, which is a big machine, and also pressing of the breast, very, very painful. And then they kept me on scanning to rule out 100% whether it is any lump in the breast like that. Then after that, from then onwards, I'm thinking that how many women will go when they have these minimum things when they get it. Although we are telling in the communities to do the self-examination, they are not doing, feeling so hesitant to do it. Recently, when I went to Mumbai to one of the institutions, after going through with them, they are doing just like a phone receiver. We have land phones, a receiver. It's an AI based, it's a handy mammo. What they did is, I went through that examination, they just kept that handy mammo on my breast. And there is an app in the mobile which has captured, and where I have lumps, then it blinks with red color. And then it is based on the size of the breast also. It will be showing how many times they have to, where they have to keep it also. So after that, the app is suggesting where to go, whether I had to go for a scan or not. Then that scan report is also loaded into it. We can go to the CHC or wherever we have it in a free of cost. And then one who is finally diagnosed can go to the tertiary care hospital or at free of cost hospital for a final examination and also to get the surgery done.
Is this the Niramai app? Is an organization called Niramai. Very similar. See, all of these use some proxies. These are not invasive biopsies. These are visual in nature or audio in nature, right? You have proxies that help you identify presence of microbial content, cancerous cells, all of that. And that is the power of digital technology. And that is what makes it miniaturized, makes it less invasive, right? Less painful even for the patient. And most importantly, at a fraction of the cost. Because to do population scale screenings, you need an order of magnitude cost saving. It cannot be 5%, 20% cheaper. It has to be 1/10 or 1/100th the cost, which is what a lot of these organizations are able to deliver. Yeah? Removing a very big barrier to testing, which is just being squeamish about it. Right? Think of it for colonoscopies, for cervical cancer scans, breast scans. The biggest barrier is that you don't feel like getting yourself tested unless your symptoms are so bad that you're just forced to get it done. Right? But because these are no different than a regular ECG or an X-ray, right? That's what these are. That big barrier goes away. The quality thing, right? Today, a lot of out-of-pocket expenses in poorer parts of the country happen because the test you get done in a local lab is not recognized when you go to AIIMS with a tertiary referral. They will make you do those tests again, right? So much money is wasted because labs themselves have poor ratings, right? A good doctor will look at your report and say, oh, yahan se kara ke aaye ho, dobara kara do. In this dobara karana is where the biggest spending happens. But if it is a digital device-led screening, it is highly verifiable on accuracy. You can actually say it is 97.2% accurate. This is the sensitivity. These are the false positives. These are the false negatives. Highly open for scrutiny. And that is a game changer in this whole diagnostic business. And finally, I think the reason why this is all meaningful, right? Why this is supposed to happen is because early detection is the huge determinant for quality of life. Anything that can be caught in stage 4 can be caught in minus stage 1, right? There are breath analyzers today which help you show your risk for cancer, and you can do something as simple as cut down your sugar and carbohydrate intake and prevent from going into a cancerous stage, right? The whole quality of life advancement for India's poorest can come and take that whole burden away from curative, make it heavily promotive and preventive focused if we do this right as community health workers. So we talked about strengthening health systems. I wanted to share very quick examples. The organization doing this work in Jhadol is Khushi Baby, and they're going to implement the biometric verified secure data collection so that the dashboard looks whatever color it's supposed to and not just green. If anyone's here from Art Park, they've created this wonderful Midas platform, which is open data for AI, properly annotated to inform the training of the AI modules, right, to enable the machine learning that needs to happen for AI to work well. IntelliHealth is a telepresence organization, which is a referral telepresence. So a community health worker at a community health and wellness center can refer to a PHC doctor can refer to secondary or tertiary doctors with the full health history. It's not just a video call. It is all digital assets required to make a good diagnosis in a very efficient manner. The listing on the right side is the digital public infrastructure that organizations like iSpirit have helped to build and then handed over to NHA. These will incrementally strengthen the India health stack and also strengthen the Ayushman Bharat digital mission, what is today most recognized for its insurance for hospitalizations can over time become vouchers for even OPD treatments, taking away the out-of-pocket expense that is incurred there, and can also become incentives, e-vouchers for preventive, right? You can give vouchers to citizens for preventing their diabetes from escalating, for reversing conditions and taking good care of themselves, reducing substance abuse, exercising more, being more heartful, right? Whatever you can do to improve your health outcomes. And these were the examples. We already discussed Swasa, you heard that. Niramai also in the mammogram example. A very simple body scan which is non-invasive, not painful. There's Cure.ai, which is a very large organization now, started as a small startup. They also do TB diagnosis, also stroke and lung cancer detections. Rakta.cure is Rakta.ai is a very wonderful organization. 4 young boys in small town Bihar that have figured out that a small microscopic image of blood taken through a prick, not an arterial draw, can show 6 different blood conditions, including leukemia and sickle cell anemia. Right? The photographic image can tell you what you need to investigate deeper. And NSV is a suite of products. They have N-Aura, which is a photo of your mouth, which will tell you if you're trending towards oral cancer. N-Cardio, which is a 3-lead ECG with a guided, so the community health worker need not be hugely trained on the 12 lead points. It guides you, कि थोड़ा left में लेके जाओ, थोड़ा नीचे लेके जाओ. It guides you. And it even can give you a red pointer कि यहाँ लगाओ. And that is like an ECG. All it needs is a tablet or a smartphone. And for cervical cancer, another very uncomfortable investigation. It is a DIY, where you can do it yourself and figure out if you just have a harmless polyp or is it, trending to a more serious ailment. So in summary, I don't know how much time, I'm probably over time. 5 more minutes, okay. Then I'll actually open it up for questions. But before I do, just a quick summary. And I hope you're agreeing with most of this, or should we revisit the whole boon or bane question, right? But doing what I do, something I've been doing for 8 years now in terms of bringing entrepreneurs, right, tech entrepreneurs in service of grassroots problems. Big believer in the fact that technology, if it starts with the problem statement, right, not with the, hey, AI can do this, but hey, what does an ASHA worker need, or what does the patient need? If it starts with the problem statement, can achieve phenomenal things, which are in order of magnitude, like an orbit leap, more useful for humanity than, say, if you did not have that tech. It starts with access to your own information. Each one of us should know where we are health-wise so that we can live our lives to the fullest, yet not be vulnerable to big health attacks. Having a lot of attention to promotive and preventive health so that curative becomes, only when absolutely needed. When you had the information, you did everything you could. After that, if it went into an ailment, then yes, that is what curative addresses, and at population scale, that's what even our capacity is set up for. To make sure that data misuse doesn't happen, it happens with consent, that each one of us feels empowered to use digital diagnostics because we know that it will not be misused. Right? There's no fear that someone might look at you as a business prospect and come after you and take you down very complex treatments, which is the fear we all have, right? Would you publicly share your NCD details? Probably not, right? But will you use it for yourself? Absolutely yes, and that's what we have to create using the way we architect our health systems. And that is why they have to be transparent, accountable, and finally affordable and effective for the population that they are setting out to serve. And as the first layer of the front line, right, which all our organizations are at, we have a very important role to make this happen. With that, I'll end and open it up for any questions. हाँ जी.
ये एक बहुत गांव में बिल्कुल दूर दराज के क्षेत्र में डेटा मैनेजमेंट की स्टोरी आपने बताई. मैं उसको कंपेयर करता हूँ एक फोर्टिस हॉस्पिटल जो न्यू दिल्ली में है और वहाँ कैसे मैनेज होता है. हम इनको कैसे कंपेयर करते हैं. एक पेशेंट जो 4 साल पहले फोर्टिस हॉस्पिटल में गया था, उसके डायग्नोस्टिक्स, उसकी फार्मेसी, उसकी सर्जरी, सारे रिकॉर्ड्स अवेलेबल हैं. उसकी फर्स्ट टाइम रजिस्ट्रेशन हुई और उस रजिस्ट्रेशन के बेसिस पे 5 साल के बाद भी पेशेंट के सारे रिकॉर्ड्स अवेलेबल हैं. डॉक्टर डेटा पंच करता है कीबोर्ड पे और प्रिस्क्रिप्शन प्रिंट होके आती है और उसको पता है कि 4 साल पहले क्या हुआ था. यही हम कंपेयर कर रहे हैं. दिस इज़ अ हेल्थ सिस्टम एक्चुअली, HMIS इन अ प्राइवेट हेल्थ केयर सर्विस प्रोवाइडर.
जी.
Now, if we compare with the government of India being managed by the Department of Health and Family Welfare and the WCD, they also have a huge NIC, information system. ये क्यों हम मैनेज नहीं कर पा रहे हैं? मेरा क्वेश्चन आपसे नहीं है, बट क्वेश्चन है
जी
कि एक छोटे से डेटा को मैनेज करने के लिए हम इतने रिकॉर्ड्स मैनेज कर रहे हैं रजिस्टर में और उसकी ट्रैकिंग नहीं होती है. अगर वो बच्चा वहाँ से माइग्रेट होके, झाडोल से माइग्रेट होके अलवर आता है
जी,
और आते हैं जयपुर आते हैं
जी,
पढ़ने के लिए बच्चा आता है, वो मैलनरिस्ट ही है लेकिन उसकी ट्रैकिंग वैसे नहीं है. आधार बेस्ड
जी,
पेशेंट मैनेजमेंट सिस्टम इस तरह से नहीं है और हम कब तक ऐसे चलेंगे?
जी. ये इसी समस्या का हल ढूंढने में निकला है. जो फोर्टिस का डेटा है वो सिर्फ फोर्टिस एक्सेस कर सकते हैं, पेशेंट भी एक्सेस नहीं कर सकते। अगर उनके पास फोर्टिस ऐप है तो शायद कर सकते हैं, पर अगर वो झाडोल के पेशेंट हैं तो वो नहीं कर सकते, राइट? जिनके पास खुद डिजिटल लिटरेट ना हो या ऐप ना हो उनके पास। जो नारायणा हेल्थ का डेटा है वो सिर्फ नारायणा हेल्थ के पास है, जो अपोलो का डेटा है वो सिर्फ अपोलो के पास है, और जो सरकार का डेटा है वो पता नहीं, वो शायद स्टेट डिपार्टमेंट के पास है। उसे तो डेफिनेटली पेशेंट एक्सेस नहीं कर सकते। तो ये पर्सनल हेल्थ रिकॉर्ड का ये अभिप्राय है कि जहाँ भी टेस्टिंग हो, वो जैसे आपके डिजी लॉकर में आपके सारे डॉक्यूमेंट्स बैठे हैं, हर जगह से मेरे आभा आईडी को लेके मेरे रिकॉर्ड्स मेरे पास रहेंगे, और ये मेरे आभा आईडी के साथ लिंक्ड है। अगर किसी और को यूज़ करना है तो वो मुझसे कंसेंट मांगेंगे, मेरे पास ओटीपी आएगा, मैं ओटीपी दूंगी, उनके पास ओटीपी आएगा, वो ओटीपी देंगे, तब वो एक्सेस कर पाएंगे, राइट? सो दैट इज़ द आर्किटेक्चर। पर इसमें सबसे बड़ी समस्या ये है कि वेयर इज़ द पॉलिटिकल विल, राइट, फॉर गवर्नमेंट सिस्टम्स टू डू व्हाट दे आर सपोज्ड टू डू, and where is the altruistic will in private players to participate and not just put it in Fortis database but also put it in personal health records. तो इसके लिए पॉलिसी चेंजेस चाहिए रहेंगे, राइट? जैसे अभी टर्शरी रीइंबर्समेंट्स में प्राइवेट पार्टिसिपेशन आने लगा है, जब स्कीम्स बनेंगी फॉर ओपीडी ट्रीटमेंट्स, फॉर लैब टेस्ट्स वगैरह, जहाँ ये वाउचर बेस्ड पेमेंट टू प्राइवेट प्लेयर्स फॉर पीपल एंटाइटल्ड टू पब्लिक हेल्थ केयर, पब्लिक स्पेंडिंग, उस किस्म की चीज़ें आएंगी, तब सब पार्टिसिपेट करेंगे। पर उसमें अभी 2-2.5 साल का टाइम है, राइट? अभी तो बेस लेयर्स बन रही हैं। इसके लिए पूरी हेल्थ पॉलिसी प्रमोटिव के लिए बनानी पड़ेगी। फ़िलहाल सब क्यूरेटिव के नज़रिए से बनी है। प्रमोटिव प्रिवेंटिव के लिए जब पॉलिसी बनेगी तब अच्छे जवाब निकल के आएंगे। पर हाँ, उसके लिए सबसे पहले पॉलिटिकल विल की ज़रूरत पड़ेगी, और वो होपफुली सम विजनरी CM in one of the states will put their hand up and kind of lead the way for the rest of the country. हाँ जी, हाँ जी।
तो उन लोगों को सरकार ने एक ओपन सोर्स HIMS और पर्सनल हेल्थ रिकॉर्ड बनाने के लिए अभी बोला है।
हाँ जी।
दे आर हैविंग ट्रायल्स
जी।
तो प्रॉबेबली अगले कुछ वर्ष में मुझे लगता है कि आभा के साथ भी उसे जोड़ा जा रहा है
जी,
और बड़े हॉस्पिटल्स को भी वो कम से कम कीमत में ओपन सोर्स एक HIMS ओपन खुला करके दिया जा रहा है
जी।
तो होपफुली ये जोड़ा जाएगा। तो
जी।
क्या आप इसके बारे में अधिक जानती हैं?
हाँ जी, हर आभा आईडी के साथ PHR स्टोरेज स्पेस प्रोविज़न किया गया है, पर उसका अडॉप्शन नहीं हो रहा, इसी वजह से जो इन जेंटलमैन ने बताया, राइट? PHC में यूज़ हो रहा है क्या, और प्राइवेट जो फोर्टिस जैसे हॉस्पिटल्स हैं वो इसे यूज़ करेंगे क्या, उस बैरियर को अब भी क्रॉस करना है। The technology is always the easiest. How difficult is it to write code, right? That always happens. But to bring in the right players, to incentivize them right, to make sure everyone feels the value coming out of participation is the difficult part. तो आपने सही कहा, इसमें कुछ साल लगेंगे।
In certain portals, it is even in the national portals, it is available. For example, TB patients can access their data if they know their Nikshay ID directly on the portal.
Correct.
Similar, I think, also with the RCH portals to a little extent, and the similar data is also available to the health system.
Correct.
So it has started off in bits and pieces in certain places, and once Abha comes, maybe it will be a lot more streamlined with ABDMs and so on happening.
The missions have used it well. Correct.
Yeah.
Yes.
So but my question or thought was not on that. Like, we are using this non-invasive hemoglobinometer. We've also used some of these other equipments before for early screening and so on. And what we generally find is that the utility of the, because it's AI based and there is the learning happening, becomes much better over a period of time. That is something that we have actually seen. But what we also deal with is that after a while the pilot phase stops and we are not able to continue it. Like we've used the ECG, we've used the retinopathy device, and then now we are using the non-invasive hemoglobinometer. But after a while, we just need to stop because we are not able to either convince the government sector to pick it up and do it on a large scale, or we don't find enough funding opportunities to continue with it. That I feel is what we are currently struggling with in our own projects. So anything that you know about that will actually help us continue with it?
Yeah. I presume you are a philanthropically funded organization. Is there a barrier in raising grant money and doing it yourself?
Yes, that is the thing. Like it is for a specific period of time. After that, we are not able to continue and persist with it. So, and also there's been a lot of the hesitation which you mentioned about the Data Privacy Act and so on. Like currently we have our, for example, we are using the non-invasive hemoglobinometer, and where the data of the person for whom we are measuring the HB levels, or rather it's a colorimetric method, so that actually goes into whichever server that they are having. We are very careful about not including the personal details of the person that we are actually measuring the HB, looking out for anemia for rather. So we are very careful about not entering the details of that particular person. We give a code number, like a roll number in school or some code like that, so that it cannot be traced back to that particular person. How much is that data protection, that DPDP Act also is going to affect all of this is another concern that we generally have.
Correct. So the data empowerment and protection, the DAPA platform, DPI is what is required in that use case. This is what makes it possible for the protection to happen, right? So it is highly compliant with all the privacy laws, but it is also empowering. What use is data if it is just locked up? You need the key to open it up and use that data when required. So you should be able to identify the individual. They should be able to say, hey, if my readings cross thresholds and it is a health-seeking trigger for me, then let me know, right? You will know first. You let me know when I should go check it out with a doctor. That is the empowerment piece. So the answers are there. We need to implement it in whatever systems we are using, right? Okay. Happy to connect offline and,
yes.
You know, and perhaps at some point I'll also publish a playbook, right? There's even an opportunity for creating a platform that all of us can use, which on one side takes care of all the patient interfacing functions, the biometrics, the connection to PHR, DAPA, all of it. And on the other side curates the Swasas and Niramais of the world to say, hey, come on the platform and do your transactions through here. These are...
So we are not very technology-driven organization, though we have few devices which we are using. We are using cervicoscope for cervical cancer screening. But what we have observed is false positive case rate is so high with these devices. Even with Swasa, we are not using that app, but we know many organizations who are using this app, and false positive cases are so high that it creates unnecessary panic in the community. So this is the challenge we face. Another challenge we face with technology is getting some app or some software is easy, but maintaining that software and that app, the maintenance cost is so high that organizations like us face real challenge to continue with that app. That happened with the Anandima app. We used it for a year, but then the maintenance cost or annual maintenance contract is so costly that we could not continue it. So we trained our staff to use the equipment which is there in that Anandima app, and we read it internally rather than. So these are some challenges organizations face, and I think during introduction of such app and such technology, we have to be very vigilant and see if it will not create more harm in the community.
Yeah. So when it is ambiguous, it could go either way. They say, yes, go get yourself tested. Because you don't want to be in a position where you said, no, everything is fine, and the patient goes back and finds out 6 months later that it was actually a positive, right? The cost of that is much, much higher in real terms. So all indeterminate results move to positives. But they have an obligation to report what is their percentage of false positives and false negatives. So you can actually tell the patient that it's showing positive, but this particular test is known to have 10% false positives. There's a good chance you may not have. All this is saying is, jaake lab mein confirmatory test karao. It need not trigger a panic, right? That's within our means to handle the reactions to a test result. And I hope you agree that it's better to get a false positive than a false negative, right? On the part of maintenance, which is probably the reason why a lot of them have moved to a pay-per-use model. Very few of them will now ask you to buy a device. They will loan you a device and take care of its maintenance, and they'll charge you for every customer whose data and results they give to you. Right? That's a model that a lot of them have shifted to. A clear distinction between a device that has been made for first world markets and a device that has been made for community health use case is that the terms of use, the pricing models, the business aspect, they would have thought through the needs of the community, right? So yes, there will be some devices that might be out there that might not work for you, but you might find an equivalent where the founding motivation for that team has been to help community health improve, right? So yeah, there's always a choice. And of course, some of them would be engineered for and priced for the premium segment. No point, kind of critiquing that, because that's what they have chosen to do.
We are working through other in the remote areas of northern Maharashtra.
Yeah.
So I just want to PHR records. In our ANC care system, there are so many records to get ANM and fill in the app. But when mothers came with the labor and referred to the higher facility, she started from HB test, maybe delay for her delivery, C-section and all these things. In the higher facility, there is no PHR have. Those Asha and ANM get from for her first ANC visit, second ANC visit and all these things. So what government dashboards is lack, because it is suffer so many mothers and all these things.
There is also a state-center conflict in certain states. Whatever is there centrally available, they will still say I'm sure if you come across the states, the Poshan app, for example, every state has a different way of using it. E-Sanjeevani, every state has a different way of using it, right? That is the reality on the ground. There are non-profits that have worked with, and Khushi Baby is an example of that in Rajasthan, right? That have worked with the state on systems change and put in a PMU at the state level and then hand-holding at every node, right? At the district, taluk, PHC level, perhaps even health and wellness center level in a community, and stitched it all together, shown them how to use it. Those are the states where that information flows a little better. But even there, you have to go plug the data collection at the source. My objective today is not to say that, hey, all of this is working and hunky-dory. Far from it, right? I'm only talking about what is possible, because the technology part is easy. The people part is difficult. And we are the people, as community-based organizations, that have a role in bridging the people gap. On, of course, the state side, we will need to build an advocacy, right? Keep bringing this up at so wherever there are Mahila Arogya Samitis in urban or whatever, and you're facilitating that, make this an agenda point, right? That is the work we need to do. Yeah.
Yeah. So whenever we are going to the Anganwadis, there are malnutrition children will be there, but they are showing very less. See, in one village there are 10 children are there, means they will show only 3 children.
Under-reporting.
Yeah. If we are starting to this recording and everything, is it linked with the same Anganwadis, this technology, what you are using, that will be in the government portal also, can we link? Because whenever we are discussing with the district administration or any discussion, that time they will not agree about that. No, not in this village only 3 children are there. Like that they will argue.
Correct.
So how we can link it with that? That is one thing.
Correct.
Second one is like pregnancy and lactating mother. If the test and everything through our technology we are recording everything, it will go to the PHC center? Can we link like that? Because the government and our technology records will be same. Can we do like that?
If the system has to work, it still has to work. You cannot solve it by creating another system. So what you said first is correct. It should link back to the same data sets that are showing up on dashboards. Right? So that would absolutely be my preferred answer, but happy to discuss offline. Yeah.
टीबी का डायग्नोसिस बहुत ही लेट होता है, इसीलिए बहुत सारा फैलता है। तो हम ऐसा कुछ कार टेस्ट जैसी यूरिन प्रेगनेंसी टेस्ट है कि जो हम स्पूटम वहीं के वहीं लेकर ऐसा कुछ कर सकते हैं क्या? इसके बारे में यू पीपल एंड फार्मा पीपल जॉइंटली ऐसा कुछ कर सकते हैं क्या, और ऐसा कुछ टेस्ट ला सकते हैं क्या? वो एक है। और लास्ट टाइम जो रिकॉल नहीं हो रहा था वो पारस का पेडियाट्रिक फंडस कैमरा है, जिससे प्री मैच्योर बच्चों का रेटिना का फोटो लेके ऑप्थेल्मोलॉजिस्ट के पास भेजते हैं। तो ऐसे हमने 2000 प्री मैच्योर बेबी स्क्रीन किए हैं। अच्छा। और वी आर हैप्पी कि हमने 60 ऐसे बच्चों की आँख की रोशनी बचाई है। अच्छा। ट्रीटमेंट होने के बाद। वंडरफुल। और विथ एंट्रा पारस
ओके, आई लुक दैट अप।
और दूसरा जो एंट्राव्यू का है उससे तो लगभग 8 लाख स्क्रीनिंग ईयर स्क्रीनिंग हो गया था। और उसका भी हमने एक कम्युनिटी मेडिसिन जर्नल में एक पेपर भी पब्लिश किया है कि एक्यूरेसी रेट क्या था। कम्युनिटी हेल्थ वर्कर जो कर रही है तो 96.9% डायग्नोसिस, प्रोविजनल डायग्नोसिस कम्युनिटी हेल्थ वर्कर ने जो किया था वो ENT सर्जन ने किए वाला एकदम बराबर आया था। तो 96.9% एक्यूरेसी वाज देयर।
वंडरफुल।